Hi guys, so my name's Sammy. I'm currently an FY3 now in psychiatry, and just gonna talk to you. It's a really casual chat. It's nothing too structured, so feel free to ask anything throughout. And I know it's about complex history, so I am going to definitely touch upon gum and psychiatry because typically they're the ones that medical students have struggled with in the past. But hopefully, I'll also cover some other things that have cropped up during my medical school years that I didn't expect to come up in an OSCE, and it just threw me off a bit. So I thought I'd just give you guys a bit of prep if that were to come up in your OSCE as well, so at least you have a bit of an idea. So really, it's just to give you a good overview on talking a bit about communication skills. I know Paul's already done a great job about breaking bad news, so I will touch bit more on communication skills because that's so key to OSCEs, and understanding basic approach to taking a history that might not be within your comfort zone, and also just to learn some phrases that are useful for you as a medical student during your OSCEs, but also so useful for you when you actually become a doctor and you're talking to real patients and you're actually doing that job, just to have a few sort of tricks up your sleeves. So okay, so I really wanted to point this out because I went to Leeds Medical School and they had something called the Global Patient Score. So your patients gave you a score, and I can't remember which year, but for some of the years, that score counted towards your final OSCE grade. So it's really, really important for you to have a good rapport with the patient. And this goes without saying, but it pays off for when you actually become a doctor and you're trying to build that rapport with your patient as well. So even if you have no idea what you're going to do in that OSCE station, just build a good rapport with your patient. And there's a few ways you can do that. These are typically the main ways you could do it, but also these ways might also help you tick box some of those things that examiners might be looking out for. So this one, a lot of people because we get the feedback back from our OSCEs, a lot of students got feedback back saying they didn't pick up on cues that the patient was leaving, whether that be because it was just too nerve-wracking during the OSCE or whatnot, but patients often do give you cues, whether it be verbal or non-verbal, and it would be useful for you to pick up on that and maybe even comment on it. So if they look really distressed, saying something like, "You look quite distressed right now, what's going through your mind," could actually be really showing sort of your empathy side. The golden minute is just to allow them to speak for a minute. Don't sort of just ask them a question and hone in on all the closed questions and bombard them with that, but instead just give them a moment to just say everything they want to say. And again, this is really important when you actually become a doctor and you're actually taking a history from a patient, because they might say a lot in that minute. And then just in general, just showing that you're actively listening, nodding your head, umming and ahhing, saying, I can see that, I hear you, and chunk and check, which Paul also touched upon in the Breaking Bad News. And then just summarizing is very, very helpful. Using the patient's own words is extremely helpful. I found that to be the case in psychiatry specifically, because some patients do find it really difficult to explain what's going through their mind. And when you substitute in a word, it might not be exactly what they're saying. So it's always just best to use their own word. And then later, when you sort of feedback or present back to your consultant, you can then substitute saying, "I think the patient is implying this," but it's always good to use their own words. And then, like Paul said, to offer written material, acknowledging their feelings. And at the end of the day, just being a human. You are there as a doctor, but you're a human first, and just showing that human side of you and that you're not just sort of going through the process is really, really important. So they're just the main sort of communication points to help you get those really good global scores. So I'm sure you've all heard of ICE by now. So it's ideas, concerns, and expectations. For us, there was always that in the MARC scheme, but even if there isn't, I think it's a really, really good starting point, or even an ending point. So I usually did at the beginning. So before I went in, they told me a bit about what they were going through, and then I'd say, okay, before I go into any questions, have you had a think about what's going on, or is there anything that you're particularly concerned about? And then they'll start telling me, oh, maybe I was looking into, I was looking on Google and I think I might have something called esophagitis, and I just want to find out a bit more about that. So it just helps to build a bit more background, and then that just helps you guide your consultation a bit better as well. And then at the end, I always, after I've done everything, I always sort of talk about expectations. So I say, okay, so we've talked about this and this. Just before I sort of go into anything else, I just want to make sure we're on the same page. So is there anything you were particularly hoping that I could do for you today? Or was there anything that you were expecting that I could do for you? And then they would be able to tell you, especially in an OSCE, they'll say, oh, I want to get some antibiotics, or I think I should get a scan because I think I've got cancer, or another thing. I just want some reassurance that I'm fine. It could be anything, but it's just nice for you to be able to build that rapport, and it just shows that you do care. And then regarding summaries, I find this really helpful, especially when I didn't have an idea as to what was going on. So when I've taken the whole history and I still don't know what's going on, it just helps you buy some time. So you just start summarizing. So you say, thank you for your information. So just let me summarize what I think I've got from you, and please correct me if I got anything wrong or if there's anything else you want to add. But from what you've told me is that you've had, for the past 6 weeks, you've had this, this, and this, and this, and this. Is that right? And then they'll say, yeah, that's exactly what's going on. And during that time, surprisingly, sometimes you might actually start thinking, oh, actually, I know what it is now. Or if you still don't, then just be honest and say, I don't know what it is right now, but we can do this and this and this. And then you can talk about your management plan. So, okay, so this is just a really brief one, and I just wanted to touch upon this really quickly. So if anyone wants to go on to Menti, just to type in what the purpose of taking collateral history is. So collateral history, and I don't want to sound patronizing, but it's just to confirm, to make sure everyone knows, it's just a history taken from someone else that's not the patient. So any other profession, it could be a professional, it could be a family member, relative, friends, anyone. So yeah, it's to fill in any gaps. So when I think about collateral history, it's usually probably from someone who's either lost capacity or isn't giving the full history, and you have some doubts, or you just want some extra information. So exactly, in the case of patients with dementia, sometimes it's difficult to assess whether their history is accurate. So it's really, really helpful to be speaking to the family. And actually in psychiatry, especially in dementia, the first, not specifically dementia, but in some psychiatric conditions, the first symptom is actually loss of insight. So they might say they're feeling fine, but then you speak to the family members and you just realize that they aren't, but they've not got that insight. So yeah, well done. Everyone's on the right track. Good. So my main point that I wanted to highlight was that it is to gather information. So just be really, really careful. And I think this applies more for when you actually get into clinical practice, because of the difficulty regarding confidentiality. Taking collateral history is literally just to gather information. You're not, depending on consent, obviously, if the patient's giving you consent to speak to the family and also to tell them about their condition, then that's fine because you've got consent. But if your sole purpose is just to take collateral history, you just need to gather the information. Don't start talking about what the patient's suffering from. Don't start talking about their prognosis. Don't start giving away things that you shouldn't be, or that might not be necessary in that particular scenario. So just watch out for that. Again, this is more for clinical practice, just as a reminder, but in a OSCE, some people have in the past just started going into the condition a bit too much rather than from a sole information gathering purpose. So, okay, so this one was dental history. So this didn't come up in my OSCE setting, but when I started working in an A&E, a lot of people presented with dental problems, and I just had no idea what to do when someone came to me about their teeth. So it's just to sort of highlight, in general, what you could ask if someone came to you with a dental problem. So you can just literally ask them, have you visited the dentist yet? They might say something like, there's been some delays, so I've actually not been able to see them. Or they said, oh, I've seen them, and they said, I've got an abscess, so they've given me some antibiotics, but it's not feeling any better, and I'm in a lot of pain right now. So just to gauge sort of what's going on. And dental anxiety is something that I picked up on. So a lot of people, dental anxiety is literally when you feel anxious about going to the dentist. And there's actually a scale called the modified dental scale that you can use to find out like how anxious they are about it. That might just help you to gauge some more information regarding like maybe they've had this problem for like months, but they just haven't seen a dentist. And then after you've got a general overview, you can start talking or asking about oral hygiene. So you can just start a bit about like, oh, can you tell me about how you look after your teeth at the moment? And then they'll probably give you some brief information, and then you can hone in a bit on things like toothbrushing, flossing, mouth rinsing, any previous, so kind of like a similar to your medical background. Just have you had any previous problems with your teeth? Have you got any known problems with crowns, dentures? And then if they come in with like a dental history, I think from an OSCE point of view, and also just from a medical point of view, always think about infectious endocarditis, because that's always something that they mention in exams about people with dental problems. So that's just a very brief touch on that. Falls history. I think this isn't particularly complicated for you guys, so I'm just going to spend 1 minute on it, and I'm sure you've been through it during your medical school training, but it's just to remind you of the structure. For falls history, it's important to have a beginning, during and after. So what happened before the fall? Did they have any pre or any oral auras? Any were they feeling any palpitations? Were they having any chest pain? Just all of the red flags to ask before the fall. Ask them what happened during the fall, or during the time that they were down. Did they actually lose consciousness? How long were they down for? Were they aware of what happened? If there were bystanders, always try and ask for collateral from them. And sometimes people with epilepsy, so this is falls/epilepsy. So people with epilepsy, sometimes they get videoed during their attack, especially children. And that would be helpful for you to be able to have a look at that. And then just after, so any sort of post-ictal symptoms, any, how long did it take for them to come round? Did they have any symptoms afterwards? Were they still feeling really groggy? Just in general, those kind of questions. But I won't dwell too much on that. Medication history has actually come up for us. So it's essentially like a medication review. So for this one, I think it's important to, well, first of all, establish what medications they're actually taking, the name, what for, and the dose. And also be aware of non-oral medications, because that's a lot of things that patients omit from their medication history that they don't think to tell you. So things like inhaler, topical creams, steroid creams, ointments, and yeah, they're the main ones in general. And then assessing compliance. To do this, you can just ask them, have you been compliant with them? And they might say yes. But if you hone in a bit more, you can ask them like just like a quick quiz, like, oh, so how often do you take this one? Are you taking this twice a day or 3 times a day? Just to clarify that they are doing it correctly, at least, because sometimes there might have been confusion. It might not be intentional, but there might just be confusion regarding how often they should be taking the medication. And duration is really important for side effects. So if someone started a medication recently and then soon after started having some problems, then you could think it might be due to side effects, but some medications, you probably expect the side effects to be within like a few months when they started, but then not expect it after 2 years or so. So less likely to be attributable to the medication that they're talking about. And then technique is an important one. And I think that's specifically the case for inhalers. I think people do find it difficult. But having said that, there are other medications that people misunderstand. So some people think some sublingual medications, they just swallow it, or some medications need to be chewed, but they don't chew it. So it's important to establish that as well. And then over-the-counter medications, I think that's important regarding just to find out if they take any other thing, and if they do, then what is their source? Is it a trustworthy source? I think the most common one that comes up in medical school is St. John's wort, which a lot of people don't talk about, as in the patients won't volunteer, but it can increase your metabolism and it can reduce the efficacy of like some medications, including the oral contraceptive. So that's important to be aware of. And then in general, just like your normal medication history, allergies, side effects, but also I think social history is quite important in this one because of recreational drugs or smoking or alcohol or other things that can have a direct effect on the medications they're taking as well. Okay, so going into a bit more about psychiatric history, I remember from a medical student, people do struggle with this and it was a bit difficult, but now that I've worked in psych for the past 8 months, it comes with practice. So it's all about practice, and the way you ask the questions is important. The way you phrase it really directs you down a particular path with your patient. If you start asking it in a very awkward way or in a way that might be offensive, it does bring about a different tone to the consultation and it does change things. So again, on Menti, there are lots of types of hallucinations out there, but if you could just note down the main ones that you think I'll be touching upon, or the main ones that you are aware of, and then we'll just quickly talk about them. So there are 4 main ones that I'm thinking of. Auditory, visual. Good, so we've got 2 out of the 4. What else can you hallucinate? Okay, fine. So it seems that auditory and visual are the most common, which it absolutely is. But people have reported other things, including smell. So they smell things that aren't there. Or somatic or tactile, so that's when they feel things that aren't there. So more commonly, they usually report like something under their skin crawling around or something on their skin. That's usually the main one that I've heard. Olfactory, they can smell literally anything. They can just, for some reason, smell burning wood. They can smell a perfume when no one's around. They can definitely hallucinate anything, basically, but these 4 are the main ones. And I think for this one, well, the way I ask auditory anyway, I say, do you ever hear voices or noises that when no one is there, or when there is nothing to explain it? And then if they say yes, it's important to establish if it feels like a real person or if it's themselves. So you can say, can you hear them in your ears, or are they in your mind? Is it your own voice? Is it someone else's voice? And then if it's someone else's voice, you can say, is it recognizable? Is it like your parent? Is it a family member? Or is it just someone you don't know? When they say they have got audio hallucinations, it's important to really get the information off that. So how many voices are they? Are they female, male? Do you recognize them? What do they say? Do they ever give you demands? Do they ever ask you to do something such as harm yourself or harm other people? And do they ever sort of tell you to talk about what you're doing? So did they ever comment on your actions, like Sammy is opening the door, Sammy is brushing her hair, or anything like that? Because they can point towards certain diagnosis. Then visual, a similar sort of question. So when do you see them? What do you see? Do you feel like they're actually there? Do you know they're not there? Are they more like shadows to you? Those kind of questions. And then everything else, so olfactory is smell. So you just ask, do you ever smell things? When it's usually associated with auditory hallucinations, but if it's not, then you can just say, do you ever smell things that can't be explained? Or do you ever feel things crawling on your skin, or other sort of sensations that you think are strange? And patients with insight will sort of answer that, and they don't shy away from it. So it's important for you to ask about it, and in a very non-judgmental way. It's important for you to normalize it. So you can say, it depending on their situation, but if they've given you a bit of history, you can say, so from in the past, when I've spoken to patients in your situation, they have experienced things such as hearing things that aren't there. Have you had anything like that? And that just normalizes it a bit and is more in a less judgy way, and makes the patient feel more at ease talking about it, because understandably some patients might feel quite concerned talking about these sort of symptoms. Okay, and the next one then, so regarding first rank symptoms of schizophrenia, there's thought abnormalities as well. So again, 4 main types of thought abnormalities. What are they? Just pop them in Menti and we'll go through them. Intrusion, broadcasting, expulsion, I think we've got the insertion. Okay, so we've got the bulk. So the 4 main thought abnormalities are thought blocking, thought withdrawal, thought insertion, and thought broadcasting. So again, these questions, like the hallucination questions, you just sort of have to be straightforward and explain the question properly. So thought blocking is when you've got a sudden cessation, so sudden stop of your thought mid-sentence. And usually you tell that from the way you speak to the patient anyway, because they'll just stop mid-sentence, or they just stop the conversation. But you can ask them a bit about, generally, do you think you can think clearly? Have you ever experienced your thoughts just stopping as though there were no thoughts left? And thought withdrawal, you can literally ask, do you ever feel like your thoughts can be removed by other people? Is there anything like hypnosis or telepathy going on? And thought insertions, ask similarly, do you ever feel like thoughts can be put into your head that aren't your own? And then thought broadcasting, you can literally ask, do you ever feel like your thoughts can be heard by other people? Or can I hear what you're thinking right now? Those kind of questions are important for you to establish all of this. Okay, so other first rank symptoms of schizophrenia include delusional perception. So as I've put on the slides, delusions are fixed, firm beliefs that are not amenable to a rational argument, and this is not in sync with any religion or cultural norms. So it's important for you to understand that this is definitely in keeping with cultural norms and religion, and regional. So you just have to be aware of that, because everyone has their own belief, and it's not wrong to believe something that might be different to your own. But if it's within their own cultural norms, then that's fine. But a delusion is when this is not in sync with that. So examples include like persecutory delusions, where they think someone's about to harm them for no reason, and also ideas of reference. So they might sort of see something on TV and then immediately say that message was for me, or I know that was for me because this and this. And then you definitely need to explore those symptoms a lot more. Good. And then last bit on the first rank symptoms is passivity. So these are people who don't feel like they're in control of their own actions or their thoughts, and they're basically influenced by an external agent. And I think this is really important to establish because of the potential risk to other people. So this one, you can, similar to the thought abnormalities, you can ask, do you ever feel as though you're being controlled by other people or by someone else? Are your thoughts or your mood or your actions under your own control, or is someone else forcing you to behave in this way? And then, especially in an OSCE setting, they'll be able to come out quite easily with these sort of answers. Okay, so sensitive questions. I won't put it on Menti because I'll be going through it anyway, but sensitive questions are usually pertaining to things like gum questions, some psychiatric questions, and like a sexual health history question usually. So yeah, so I just wanted to sort of briefly talk about opening the consultation. So it's always nice to give patients warning shots as to what you're going to ask. So you can literally say, so I'm going to ask a few questions about your alcohol intake. I'm going to ask a few questions about your sex life. Is that okay with yourself? You can normalizing it is great, and it's really helpful in an OSCE setting. So you say, these are routine questions we ask everyone, just answer as much as you feel comfortable. If there's anything you don't want to tell me, then that's also within your own rights. And then just make sure that you're trying to portray yourself in a non-judgmental way. So I'm not here to judge, I'm just trying to help, therefore as much information I can get is best. But also talking, I think it's important to include a bit about confidentiality. So you can say something like, everything I talk about is confidential within the boundaries of the team looking after you. I will be trying to keep your confidentiality as per your right, but if I do identify anything that might be of significant risk to yourself or to other people, then in that case, I might have to speak to someone else. But obviously I'll try and discuss that with yourself first. And that's just to sort of preempt the confidentiality aspect of the conversation. Okay, so on asking these sensitive questions, kind of like Paul was saying, you just need to be straightforward. You have to just be unambiguous, straightforward, and just ask the question. If you make it awkward, the patient's going to be awkward, and it's just going to be a very unflowing conversation. Just be professional, be non-judgmental, and ask the question outright. And don't try to use any jargon, because that's when you start getting yourself in a pickle. You feel like you're trying to make it less awkward, but actually you're just using all these words that people might not understand, and then you have to start explaining what you're trying to say, and then it just gets very messy. So things I like, specifically things like from a sexual health history point of view, I just say, have you noticed any changes in the amount of vaginal discharge? When you're asking about, so things like, when I say don't use jargon, I say, have you had any dyspareunia? So like the typical lay term, you wouldn't use dyspareunia. So you can just say, during sexual intercourse or during sex, do you ever feel pain? Again, similarly, postcoital bleeding. So just say, after sex, have you ever noticed any bleeding from the vagina? And be straightforward and ask about, have you had any sexual transmitted infections in the past or currently? Have they been treated? And then for males, just again, similar questions. Have you noticed any discharge from your penis? Have you noticed any difference to the appearance of your penis? Just be very straightforward and professional about it. This is sort of talking about last sexual contact, because sometimes you do have to ask specifically about that. And I know I keep banging on about this, but you just have to ask about it straightforward. So you can just say, so I'm going to ask a bit about the last time you had sex. Can you please tell me when that was? Did you consent to it? Were both parties happy to consent to it? What is your relationship with this person? And then they might say, what do you mean? And you can say, was this person a regular partner and like a boyfriend or husband, or was it a one-off? And then you can ask about the partner. So about this partner or this person you slept with, do you know any information about him or her? Do you know if they have HIV, if they have any sexually transmitted infections? Have they had previously been having sex with other people that you're aware of? In real life, most of the times they say, I don't know. In an OSCE, they might have a bit more information to provide you. Type of sex is really, really, really important for you to stratify your risk. So literally just ask, what kind of sex did you engage with? Did you engage in anal sex, oral sex, or penetrative sex? And they will just tell you. Asking about contraception, did you use any contraception? Was it barrier methods such as condoms, or was it just the pill, or did you use anything at all? And then ask them about their sexual partners in the past 3 months as well. So it's like, okay, so we've just established a bit about the last sexual contact, but can I just also ask how many other sexual partners have you had in the past 3 months? And then you have to sort of ask about similar questions relating to those partners if they do volunteer anything. And specifically regarding HIV is probably really important to ask. And then risk assessments. This is going back to psychiatric history. Never, ever, ever, ever forget to do a psychiatric risk assessment, especially for someone presenting with high risk, whether they be depression, manic, schizophrenic, any of that. But in general, anyway, it's very applicable, and you're kind of doing it all the time anyway. But it's now actually showing that you're asking these questions, and you're doing it for yourself and for other people, like about risk to themselves and risk to other people. Again, you can normalize this. So you can say, when people feel down and depressed, sometimes they can feel that life is no longer worth living. Have you ever felt like this before? Have you had thoughts of taking your own life? How often do you get these thoughts? What's stopping you from doing it? Have you made any actual plans to end your own life? Have you tried to hurt yourself at all? When you hurt yourself, is it more as a release of your emotions, or do you actually want to end your own life? So all of these are very important part of the risk assessment, and depending on how much time you get in an OSCE, will depend on how much you can ask. But in real life, this is the main bit that the consultant wants you to tell them about, because that's how they manage the patient. They want to know how much input this patient will be needing. And sort of just to touch upon is be careful with phrases like okay and right. I've heard that on many occasions. From sort of when we're practicing with my friend's point of view, and sometimes it's just something as a patient you pick up on, but you don't know as a candidate. So for example, in the Breaking Bad news, someone might say, I've got, they'll say you've got cancer, and then you say, and then the patient will go, oh, I can't believe I've got cancer. This is so distressing. My parents had cancer as well, but I didn't think it happened to me. And then as a candidate, they'll go, okay. And then the patient went, no, it's not okay. It's definitely not okay. What do you mean it's okay? And then she got really mad. This wasn't in the real OSCE. This was a practice, but presumably you can understand where they're coming from. So I think you just need to be really careful with these phrases that just come out. And I know that as a candidate, you probably didn't mean it in that way. So just be careful with those sort of phrases. So instead, what you could say is just a sort of acknowledge what they say. So you can just say, okay, I see where you're coming from, and I can see that you're really distressed, and I apologize that we were in this situation, and sort of do that and avoid saying right or okay. And exactly, yeah, well done. So I understand that it's difficult. The situation isn't ideal. I'm very sorry that you're in this current situation. Just anything like that is better than going okay, because it can come off quite passive. This is a hard situation. Yeah, definitely. So that's the bulk of what I wanted to talk about. I won't talk about telephone consultations too much, but essentially it's just to remind you that that is coming up more. I don't know in an OSCE setting, probably not, but in real life. And it's just important to make sure that you know who else is on the other side of the phone. And if telephone consultation isn't appropriate, then just rearrange for a face-to-face. That's just something to point out. So really quickly, a quiz. There's only 3 questions. Which of the following is not a first-rank symptom of schizophrenia? Okay, yeah, good, well done. So seems like most people are clicking on flight of ideas. So yes, auditory hallucinations, delusions of thought, and passivity are all related to first-rank symptoms of schizophrenia, but flight of ideas is usually more mania. Good. And then next question, which of the following is a non-verbal cue? So this is regarding communication skills. Yeah, good. So as you can see, all the others are relating to verbal, and they are cues, but they're all just verbal cues. Non-verbal cues include things like eye contact, hand gestures, facial expressions. They're all non-verbal cues, and just watch out for them in a history taking or communication station. Last question, which one of the following is one of the 4 pillars of medical ethics? Okay, so we've got one for autonomy. Okay, interesting. So autonomy is actually the correct answer. So I think of it as the 4 pillars and 3 C's. So the 4 pillars are autonomy, justice, non-maleficence, and beneficence. And then the 3 C's are confidentiality, consent, and capacity. They all typically would just relate to medical ethics anyway, but the actual 4 pillars aren't the 4 C's. So I think of it as the 4 C's and, the 4 pillars and 3 C's. Good. So in summary, I hope that you've now got an overview of the key communication skills that you should have for building a good report. And I hope I've given you a brief insight into how to take some of the more difficult histories. Sorry, that was a very quick whistle-stop tour, but there's lots of resources out there that you can look at, and they do just write it out, like write out the phrase for you. So just have a look, especially for some of those gum stations, and think about how you would phrase it. But ultimately, it's all about practice, practice, practice. Do as many practices as you can with your friends, and you will just end up asking it more naturally and professionally.